Hello, my name is Anastasia Vanetrixikusianto, student number 138 from small group discussion B5. In this video, we would like to present our student project. The topic is Anatomical Aspect of Urolithiasis. These are the members of our small group discussion. And before we jump to the further explanation of this topic, I will explain the background of our student project. Urinary system has an important role to filter blood and remove waste. One of the most common diseases is urolithiasis. Urolithiasis is the formation of stones that can occur in kidney, ureters, bladder, and also urethra, basically in every part of urinary system. There are some complications which result from the different sites of urolithiasis. Anatomical abnormalities may complicate the surgical procedure and affect treatment choice. That's why in this paper, we will provide a further explanation regarding urolithiasis, starting from its definition, epidemiology, etiology, pathophysiology, and also the anatomical aspects. These are the research questions and the purposes of this student project. And these are the benefits.
Hello, my name is Udayana, student number 173. Before we jump into the main topic, I'm here to briefly explain the definition and epidemiology of urolithiasis. Well, by definition, urolithiasis is a condition when renal stones migrate into the remainder of the urinary collecting system, which includes the ureters, bladder, and urethra from the renal pelvis. Next. This condition is actually preventable, and there are several studies of its epidemiology, where in the US, urolithiasis affects about 1 out of 11 people and is commonly seen in obese, overweight, and/or male patients. Another study said that most Asian countries have experienced an increase in the prevalence of urolithiasis in the last few decades, and the highest prevalence rate was seen in the West, South, and Southeast Asia. Here are some examples of Asian countries and their data, where South Korea went from 3.5% to 11.5%. Thailand went from 1.4 to 16.9. Saudi Arabia went from 6.8 to 19.1, and Israel went from 1.2 to 9.2%. Meanwhile, in Indonesia, a study stated that the prevalence of kidney stone sufferers is 0.6%, or is seen in 6 people per 1,000 population.
My name is Ayuni Putri Adini, student number 141. Urolithiasis occurs because of several factors, such as a patient diet, prior medical or medication history, family history of urolithiasis, and some environmental factors. Several diet habits which are the risk factors for the stone formation include low oral fluid intake or wrong choice of fluid hydration, low citrate intake, low calcium intake, high animal protein intake, high oxalate intake, and high salt intake. Patient with prior chronic kidney disease, hypertension, gout, diabetes mellitus, hyperlipidemia, obesity, endocrine disorders, and malignancies have higher risk of urolithiasis. Patients with obesity, hyperlipidemia, or type 2 diabetes mellitus have higher risk in developing calcium oxalate or uric acid stones. Another study showed that adiposity in obesity has an important role in increasing the risk of urolithiasis. Patients with a history of proteus or Klebsiella infection tend to develop strophic stones because of their ureas that produce ammonia and increase the urinary pH. Meanwhile, several types of medication that can increase the risk of urolithiasis are protease inhibitors, such as atazanavir and indinavir, and ceftriaxone. Several surgical procedures that lead to malabsorptive post-surgical states have shown increased calcium oxalate stone formation because of high urinary oxalate level, low urine citrate, and oliguria. The genetic factors that are associated with urolithiasis are SLC3A1 and SLC7A9 gene mutation, which lead to cystine stone formation by affecting the cystine metabolism and transport. The environmental factors that increase the stone's formation are high ambient temperatures and long exposure of lead and cadmium.
Hello, my name is Iwan Mabus Abagas Putra with NIM 19025111050, and today I will explain about the pathogenesis of urolithiasis. Urolithiasis occurs when the crystal concentration of the urinary stone starts to increase and supersaturate the urine, leading to collection and crystallization inside the renal parenchyma and formation of the renal calculi. These crystals will continue to aggregate until they are large enough to cause a hydronephrosis due to obstruction of the urine passage and upstream dilation of the renal pelvis and ureter. These aggregates are also able to become symptomatic, which presents as pain if they migrate into the ureter. The colicky pain symptoms of urolithiasis occurs because of increased luminal tension as the stone passes through the ureter and prostaglandin release from hydronephrosis. Obstruction due to urolithiasis usually happens at three narrowing areas of ureter, which are ureteropelvic junction, an area which ureter cross over the iliac vessels, which is called as pelvic brim, and ureterovesical junction. The key factors in the urolithiasis formations are crystal nucleation and growth, with the contribution of urine supersaturation and organic materials as the driving force for this mechanism. The growth and aggregation of the urolithiasis crystals can be described by two theories, which are free particle theory, that explains the growth and aggregation of the crystal occurs inside of the urine of the tubules, followed by blockade of urine outflow from tubular openings and smaller stones formation. And the second theory, which is fixed particle theory, which explains that the stones of urolithiasis are formed and attached to renal plaques, which are rooted deeply within the loop of Henle's basement membrane.
My name is Savina Tandi with student number 048. The position of the kidney is in the posterior abdominal wall. Kidney lies on the T12 until lumbar tree. Size of the kidney is 10 cm long, 2.5 cm thick, and 5 cm wide. Right kidney is slightly lower than left kidney. It is because of the pressure from the liver to the right part. Kidney has been shaped the anterior and posterior surface of the kidney. Kidney has superior and inferior poles. Diaphragma separates the kidney superiorly to the preauricular cavity and 12 pair of ribs. There are lateral and medial margin of the kidney. The medial margin is concave, meanwhile the lateral margin is convex. Renal and sinus and renal pelvis are also located in the medial margin of the kidney. Renal consists of three parts: renal cortex, the most superficial part, renal medulla, and renal pelvis. Vascularization of the kidney is the renal arteries that rise from the aorta, renal veins, and the lymphatic vessels of the kidney. Ureter is 25 cm long. Ureter connect the kidney and the urinary bladder. Ureter constrict into three parts that potentially to be obstructed. First, in the junctions of the renal pelvis and the ureter. Second, in the pelvic brim where the ureters cross. And third, in the passage of urinary bladder wall. Arterial supply of the ureter is from the several arteries, such as renal artery, testicular or ovarian artery, abdominal aorta, common iliac artery, internal iliac artery, inferior vesical artery, and uterine artery in the female. The urinary bladder located in the pelvic cavity and will expand superiorly into abdominal cavity when filled with urine. The apex of the bladder is pointed towards to the top of big symphysis. The base of the bladder is shaped like an inverted triangle. The superior surface is dome-shaped when empty and ballooning when bladder fills. Neck is the most fixed and inferior part of the bladder. Trigone is the smooth triangular area between the openings of the urethra and the ureter. Blood supply of the bladder mainly from the branch of internal iliac artery. In female, the urethra extends from the detrusor muscle of the bladder, specifically in the anterior inferior from the internal urethral orifice, then continue to the front wall of the vagina through the pelvic diaphragm, external urethral sphincter, and perineal membrane. The urethra will pass to the vagina. Internal pudendal and vaginal arteries or vein are the vascularization of the female urethra. Male urethra is longer than female. In male, urethra divide into four parts: preprostatic or intramural part, prostatic urethra, intermediate part, and spongy urethra. Blood supply of the male urethra supplied by middle rectal artery or vein, internal pudendal artery or vein, and inferior vesical artery or vein.
My name is Putu Arya Radi Bramantia, with student number 181. Urinary stone disorder is one of the oldest disorders known to man, yet the anatomic location of the urolithiasis and its chemical composition vary from one geographical location to another. The most frequent anatomic site for all urolithiasis is the urinary bladder, followed by ureteric lithiasis. It has been studied that ureter has three sites of narrowing, where stones become lodged. The first perceived narrowing, on contrast urography, occurs at the level of the ureteropelvic junctions. The ureteropelvic junctions represent a functional narrowing which opens during a peristalsis as opposed to a true anatomic narrowing. The next perceived narrowing occurs where the ureter crosses anterior to the iliac vessels to enter the true pelvis at the level of the pelvic brim. This appearance is from a combination of extrinsic compressions of the ureter by the iliac vessels to the necessary anterior angulation of the ureter as it crosses the iliac vessels to enter into the pelvis. There is, however, no intrinsic change in the ureteral caliber at this location. The final site of narrowing, which represents a true reduction in ureteral caliber, occurs at the uretrovesical junction, where the ureter course through the bladder wall to the ureteric orifice. The intramural ureter, therefore, represents the narrowest part of the ureter.
I am Lukoma Yumilaviwanda with student number 133. I will explain about the anatomical abnormalities that contribute to increased risk of urolithiasis. Several anatomical conditions can increase the risk of stone formations in the kidneys by causing urinary stasis, which leads to sediment condensation, crystallization, and the formation of calculus or kidney stones. Number 1, medullary sponge kidney or renal tubular ectasia is an anatomical abnormality caused by abnormal embryogenesis of the distal nephron. 70% of patients with MSK will develop kidney stones. This occurs because the dilated collecting ducts and case cause distal tubular acidosis and nephrocalcinosis from a urinary concentration defect. This condition will lead directly to hypocitraturia, hypercalciuria, and the formation of kidney stones. Number 2, UPGO. Obstruction of the uretropelvic junctions results in urinary stasis, which, together with metabolic abnormalities and a genetic predisposition, increases the risk of lithiasis. Number 3, calyceal diverticula. Calyceal diverticula are sacs that emerge from the calyx or pelvis with an epithelial lining and a muscular layer. The diverticulum cavity is connected to the central collecting system by a narrow channel. Kidney stones are found in 50% of calyceal diverticula cases. Number 4, urethral strictures. Urethral strictures is a condition of narrowing of the urethra that causes urinary tract obstruction, usually caused by injury to the mucosa and surrounding tissue. Isolated stones in the urethra account for 2% of urolithiasis, which is often the result of stones migrating from the upper urinary tract. Number 5, vesico-urethral reflux. Immature prevention mechanism against reflux or failure due to anatomic abnormalities cause urine that has accumulated in the bladder to flow back into the renal calyx through one or both ureter. This condition, known as vesico-urethral reflux, is an important cause of kidney damage in children and is commonly identified in children with urolithiasis. Number 6, uretrocal. Uretrocal is a cystic dilatation of the terminal ureter that causes bladder muscle defects to renal parenchymal abnormalities. Uretrocal can become obstructed with large stones, complete urethral occlusion, and result in renal colic. Horseshoe kidney. Horseshoe kidney is an anatomical abnormality in the position, rotation, and vascular supply of the kidney. There are functional renal masses on both sides of the vertebral column that fuse together with the ureters that remain uncrossed from the hilus from the kidney to the bladder. The two renal masses are connected by an isthmus in the middle or laterally. Horseshoe kidney complications are associated with urethral obstruction and impaired drainage, including UPGO, hydronephrosis, infection, VUR, and nephrolithiasis.
So hello everybody, my name is Lalita Samalo with student number 156, and I'll tell about the relationship between anatomy and clinical signs and symptoms of urolithiasis. Signs and symptoms of urolithiasis felt by each patient will be almost the same, starting from asymptomatic to critical ill. The common symptoms include unilateral colic or abdominal pain that often goes away, nausea, vomiting, microscopic hematuria in 90% of the cases on urine analysis, and fever. The onset of these symptoms can range from sudden to gradual. Patient with urolithiasis presented as acute flank pain with a very severe level, and this pain will radiate to the abdomen up to groin, testicle or tip of the penis, and labia. This pain is consequence of a combination of several mechanisms, such as localized inflammatory changes induced by the stone, activation of an intrinsic urethral pacemaker lead to the increase of proximal peristalsis, spasm of urethral muscle, and swelling of the kidney, accompanied by irritation, capsular stretching, and edema. Pain with intensity that is getting stronger can be followed by nausea and vomiting. Nausea and vomiting may be caused by the origin of the urogenital tract as an embryo. Patient may experience chills, fever, or other systemic symptoms as the sign of infection. When severe cases occur, the stones that obstruct the urinary may develop into a source of sepsis and potentially life-threatening, and it will need emergency decompression surgery. The physical examination may let out the tenderness of the costovertebral and hypoactive sound of the bowel. The area of the testis and pubic can also be tender. Other than that, there may be the presence of fever as an indication of infection. It may also appear of tachycardia, hypertension, and microscopic hematuria. From these symptoms and physical examination that can be found in the patient with urolithiasis, there are some differential diagnoses to be considered, such as pyelonephritis, renal abscess, appendicitis, diverticulitis, hernia, acute epididymitis, cholecystitis, pelvic inflammatory disease, ectopic pregnancy, ovarian torsion, pancreatitis, renal artery aneurysm, small bowel obstruction, dysmenorrhea, constipation, and spontaneous abortion.
Hello, my name is Ferdinand with digit number 108. So for the supporting examination, in patients who are suspected of having urolithiasis, several investigations can be carried out to make definite diagnosis of the patient disease, such as first, urine analysis with a microscope can show the presence of absent or presence of hematuria, leukocyte esterase, nitrite, and white blood cell in the patient's urine, as well as other additional examination such as complete blood count, lipase, CMP, amylase, lactic acid, and blood culture in patients with positive SIRS criteria. However, the degree of hematuria cannot be used to estimate the presence or size of these stones. In addition, it is important to check the pH of the urine and the presence of crystal in the urine, because usually in patients with urolithiasis, the urine is acidic and crystal can be found. Other examination can be in form of imaging examination, which can be selected based on the patient's body habitus, cost, consideration of radiation exposure, and gestational age if the patient is pregnant. First, renal ultrasound can be performed to diagnose urolithiasis and is one of the most ideal examination for children, pregnant women, and patients who have history of not being able to tolerate contrast agent due to minimal radiation. Using ultrasound, stones can be identified if they are in the kidney, pieloureteric, and vesicoureteric junction, and can identify hydronephrosis. The imaging from the condition is echogenic or bright white. The second, X-ray examination of kidney, ureter, and bladder may also be performed if radioactive stone formed from calcium, phosphate, and oxalate are suspected. Third, MRI can also be considered because based on the literature, MRI has a higher sensitivity and specificity than renal ultrasound, but is still below the CT of IVP. MRI can be used to treat hydronephrosis and is more advantageous because it has three-dimensional imaging and without radiation. However, the cost required is 3 times higher than CT, and not all hospitals have MRI equipment. The main modality in this imaging is a CT scan in the form of intravenous pyelography or IVP, because it can provide complete information in the form of size, location, and radio density of stones in the patient's body. However, for IVP, the drawback is that it has radiation because it uses imaging with contrast media. Therefore, supporting examination must be adjusted to the patient's body condition and, if possible, avoid using contrast media if other supporting examination are sufficient for diagnosis.
Hello, my name is Putri Agnes Monica with number student 100. So let me explain more about the treatment modalities of urolithiasis. So there are two phases for treatment of urolithiasis. First is for the acute phase, second is for the elective management. For the acute phase, we can use NSAID or oral analgesic to reduce the colic pain and also to make the ureter relax so the stone can pass easily from the ureter. And second, we can use antiemetic, and also we can use fluid resuscitation for the acute phase. And second, for the medication treatment, first we can use tamsulosin to relax the smooth muscle of the ureter for the stone size under the 10 millimeters. And second, we can use alkalinization. Alkalinization is potassium citrate and also sodium bicarbonate to lowering the acid state through chemolysis to prevent the production of the uric acid stone. And the third, we can use hydrochlorothiazide or diuretic to reduce the production of the calcium stone. And the last, we can use antibiotics to prevent the production of trophic stone from the infection. And for the surgical treatment based on the anatomical site and also abnormality of the anatomical site. And for the first, there are two anatomical states for the surgical treatment. First is for the proximal and distal ureter. So for the proximal and distal ureter with size of stone under 10 mm, the first choice is ureteroscopy. And for the proximal and distal ureter with stone size over 10 mm, we can use shock wave lithotripsy. And for the renal stone in the upper, medial, and lower pole with size of stone under 10 mm, we can use shockwave lithotripsy for the first choice. And for the stone with size 10 until 20 mm, we can use shockwave lithotripsy for the first choice, or also we can use endourology. And for the last is for the stone with size over the 20 mm, we can use percutaneous nephrolithotomy in the kidney stone.
My name is Dias Baskaras, student number 168. Anatomical importance in surgical treatment of urolithiasis. There are various surgical options available to treat urolithiasis, each with their own benefits and risks involved, with the optimal approach to managing urolithiasis factoring in size, location, and composition of stones, as well as patient comorbid conditions and preoperative evaluation, such as laboratory testing and preoperative imaging. A CT scan result is required to assess stone burden and distribution, and provides information regarding system anatomy, structures adjacent to the kidney, and possible anatomic variants present. Abnormalities in anatomical structures may inhibit a surgeon's ability to clear stone fragments from the urinary tract. Therefore, acquiring preoperative imaging is imperative to decide surgical approach. Possible abnormalities discoverable by imaging is as follows: ectopic kidney and/or fusion anomaly, congenital kidney disorders, complex stone anatomy, etc. Shockwave lithotripsy or SWL is the most common performed procedure to treat urolithiasis. The procedure has been established as the first-line option to treat urolithiasis, with renal stones being smaller than 2 cm in size. However, in patients with calyceal diverticulum, SWL is not able to produce adequate fragmentation of the stones due to the narrow and long infundibulum, stopping stone fragments from passing. On the other hand, a percutaneous nephrolithotomy approach involving renal access, renal stone removal, and ablation of calyceal diverticulum, and placement of nephrostomy tube, and RIRS method show better stone-free rate outcome in patients with diverticulum. And according to the Urological Association of Asia Clinical Guideline for Urinary Stone Disease, SWL is deemed ineffective at treating renal stone in patients with horseshoe kidney with calical diverticula, whereas retrograde intrarenal surgery or IRS and percutaneous nephrolithotripsy PCNL are recommended with consideration of the stone burden. Miniaturized PCNL and endoscopic combined intrarenal surgery or ECIRS could also be an option depending on the renal stone size and location.
Hello, my name is Pratista and my student number is 2027. So now I'm going to explain the relationship between anatomy and complication of urolithiasis. Urolithiasis can lead to a variety of complications if it's not treated promptly or completely. A few examples. The first one is sepsis and ureteral obstruction. Ureteral obstruction occurs when the stone obstructs the ureteropelvic junction and ureterovesical junction. Obstruction will give the bacteria the opportunity and time they need to attach to the urothelium and infect the host. Furthermore, the stone will travel down the length of the ureter, causing injury or inflammation and leading to sepsis. Second, acute or chronic renal failure. Acute or chronic renal failure is usually caused by the stone that broke the ureters bilaterally, stones in a single kidney, sepsis with multi-organ failure, or chronic pyelonephritis as a result of tubuloglomerular feedback mechanisms in the setting of intratubular elevation. Ureteral obstruction is associated with renal vasoconstriction as well as decreased glomerular filtrate rate and renal blood flow. If this process continues, it will result in renal hypoperfusion and glomerulosclerosis, which will lead to chronic renal failure. Third, ureteral strictures. Ureteral strictures are frequently caused by the aggressive expulsion of stones that have been lodged in the urethra for an extended period of time. This can result in a local inflammatory response in the uteral wall. Uteral strictures are most commonly found in uteral dilatation near the segmental strictures. The last one is fistulization. In general, renal fistulas connect to nearby organs such as the large intestine, peritoneum, spleen, and skin through the psoas muscle. Stone in the urethra can put pressure on the bladder wall, leading to necrosis and the formation of a fistula. Fistula associated with urolithiasis are uncommonly reported because ureteral stones are typically diagnosed using ultrasonography or X-ray examination, but fistulas are difficult to detect using these modalities.
Hello, my name is Krisna Paramita Karnamaya with number 170. Urolithiasis is the presence of renal stones in the urinary tract. In Indonesia, the estimated prevalence of kidney stone is 6 out of 1,000 individuals. Several risk factors include diet, such as low oral food and calcium intake, medical history, such as gout and diabetes mellitus, medication history, such as Triaxone, family history, and environmental factors, such as lung, lead, and cadmium exposure. These risk factors lead to crystal formation. Then, renal stone is formed when the crystal concentration increases and nucleates inside the renal parenchyma, driven by urine supersaturation. These aggregates may then migrate out of kidney into the urinary tract. The most frequent urolithiasis anatomical sites are urinary bladder and ureter, especially at UPJ, intersection of ureter and iliac vessels, and UVJ. Several anatomical abnormalities can increase stone formation risk, including MSK, UPJO, urethral strictures, and horseshoe kidney. Anatomical related clinical manifestations include unilateral abdominal pain, flank pain radiating to T10 until as for dermatomes, including abdomen and genital, and colic pain in ureteral stone cases. Several laboratory and radiological examinations can be carried out. An anatomical aspect can be assessed through radiological examinations. For example, renal ultrasound is able to identify stones in kidney, UPJ, and UVJ. Management for urolithiasis is divided into acute and elective phases. Anatomical sites and abnormalities are especially important in deciding the elective management. Tamsulosin can be used for less than 10 mm ureteral stone with no anatomical abnormality. For more than 10 mm stones, surgical procedures can be chosen. PCNL, ASWL, and URS are the options for renal stones. Meanwhile, PCNL can't be used for ureteral stones. The surgical approach chosen should take into account the anatomical abnormality. For example, patients with horseshoe kidney and calcial divertical cannot be treated with SWL. PCNL and RIRS are recommended instead. Stones' anatomical sites are also associated with the complications of the disease, such as ureteral obstruction in UPJ stones and fistulization to large intestine and spleen in renal stone cases. To conclude, anatomical aspect is especially important in the diagnosis and treatment of urolithiasis. Furthermore, the anatomical sites of urolithiasis also determine the resulting complications of the disease. Therefore, it is important to fully understand the anatomical aspect related to urolithiasis in order to improve the urolithiasis patient's prognosis. Here are our references. Thank you.